Hello, everyone, and welcome to our webinar on emerging therapies in Parkinson's disease. My name, as Devin mentioned, is Soania Mathur. I'm a family physician and someone who was diagnosed with PD over 25 years ago now. I'm privileged to serve on the board of directors for the Davis-Phinney Foundation, and I also have the pleasure of being your moderator today. Neurological disorders, as we all know, or hopefully know, are the world's leading cause of disability. And of those illnesses, Parkinson's disease is the fastest growing. The number of those living with this disease is set to double by 2040. Yet Parkinson's continues to be a disabling condition, progressive, and currently incurable. There is undoubtedly an urgent need for better treatments, and the research into those treatments continues to move forward. Progress is being made to minimize the impact on the quality of life for those faced with the challenges that PD brings. And we'll talk about some of those emerging therapies today. To help us navigate what's new in this area is Dr. Michael Okun. Dr. Okun is a movement disorder specialist and is currently chair of neurology, professor, and executive director of the Norman Fixel Institute for Neurological Diseases at the University of Florida Health College of Medicine. He is an author of Ending Parkinson's, Living with Parkinson's Disease and Parkinson's Treatment, 10 Secrets to Happier Life. Excellent books. I recommend them highly. Thank you for joining us today, Michael.
It's such a pleasure to be here. And, this is our yearly appointment, where we get together and we get to have a great time talking about, where the field's going, what's exciting and everything. And so thank you for having me back. It's great.
It's great. It's always, I always learn so much from these sessions. So I'm really excited to get going. So the way I tend to look at the therapies is that there are sort of two tracks, one being symptomatic treatment and the other being disease modifying, both important because until we can modify the trajectory of this disease, it's really important to optimize quality of life for those living with PD. So if it's okay with you, let's first take a look at those new therapies that target symptoms of Parkinson's disease, be they motor or non-motor, both of which are debilitating and impact the life experience of those of us that are living with PD. And the one I wanted to get started with was the Levodopa continuous infusion. And one of the problems, as I know people listening will understand, is with the medication, taking a medication like Levodopa, there's all that variation in the amount of dopamine replacement in our system, which leads to differences in effectiveness at any one time. And there are some products that are delivering dopamine by different methods to sort of address these fluctuations or on and off periods. One of the most recent innovations is available to patients being infusion under the skin. So could you tell us more about that delivery system? What are the advantages, any concerns there may be, and when you think someone should consider it?
Yeah. So just so everybody knows, we're not as smart as you think we are as scientists. And we've been kind of at this for a few decades trying to get dopamine across the skin. This, Soania, is not an easy thing to do. Lots of scientists have tried, lots of scientists have failed. And of course, we are a product of our failures. We want to fail a lot in order to succeed. Now, the one of the fundamental principles here is that dopamine it's sort of, chemically, we call them ethyl esters and methyl esters, and these things just don't like to go across the skin. However, recently, a couple of approaches have really, kind of broken through and allowed us to be able to do what we're doing in diabetes and somewhat what we do in cancer. And sometimes you'll see folks that have diabetes and cancer, and they'll have kind of what looks like a big patch on their arm, right? And it'll have something sticking out of it. And what's sticking out is like a delivery cartridge. It's got some sort of chemical that's going across. It might be helping with blood cells in cancer. It might be helping with nausea. And in diabetes, it might be giving insulin. Now, the advantage here to this system is if we can give something continuously and it can go just underneath the skin. And so that's what I mean, Soania, when we're saying sub-Q, when you see somebody write SQ on a prescription pad, it means sub-Q. It goes underneath the skin. The idea here is that you want to be able to deliver something without having to go into a blood vessel, okay? So you just want to be able to put it right up next to the skin, stick it right just underneath the skin. Almost anybody should be able to do this, okay? Shouldn't be that hard to do. And then, pop, put on however that patch is going to stay on there and be able to either put a cartridge on it or replace the patch. And so it's sort of a pump patch sort of phenomenon. And what it does is it allows continuously, then over time, to just sort of push the chemical up underneath the skin, and then from the skin, it's going to get picked up by the blood. Okay. And then once it gets in the blood, it gets into the circulation. Now, the big advantage here, Soania, is that with the other pump, we're having to put that tube into the stomach. So you're going to have to make a hole and put it to the here. We're just going to do what the diabetics and what the folks that in cancer are doing. We're going to get it right up underneath the skin. Okay. It's going to be good for motor fluctuation. So what is it going to be good for? It's going to be good for folks who have off time. Okay. So if you have a lot of off time or even a little off time that you're not able to manage, okay, that's going to be good. It's going to be good for folks that want to get rid of some of, or maybe all of, but in some cases, we be careful about what we promise in Parkinson because it's, such a diverse group of folks that have different needs. But the idea being that if you could have a continuous release thing and you could get rid of a lot of the medications that you're taking orally or some of the medicines that you take orally, you're going to reduce off time. You have the potential to improve dyskinesia, particularly in mild to moderate dyskinesia. We're not sure in more moderate to severe dyskinesia, so we'll have to see how that goes over time. And then things like bradykinesia, things that respond to dopamine. Now, there is also a pump. So there's two of these now for dopamine, straight up dopamine. There's also a pump available in some countries for apomorphine, which is a dopamine agonist. Okay. And, the way that we look at this is we're seeing, 2+ hours of increased on time, which is really, quite a nice, response. Maybe not as much as you might see with something like deep brain stimulation, but a really, really robust response. The last thing to watch out for is the same thing that we see in these therapies across other diseases. You can get nodules. So if you're continuously putting in a chemical underneath the skin, things can get inflamed, it doesn't belong there, and you can form these little nodules. And so we're just going to have to see how that goes. So far, so good with the trials. And then everybody out there is saying, okay, what's new? When's it coming? It turns out the FDA liked it. The first patients have actually, been implanted in Canada just here in the last week or two, which was really terrific. And they're working on the manufacturing system. So it's not just getting the drug, but when you have a device along with the drug, you've got to get approval of your entire, quality safety line to manufacturing. And so hopefully we're going to see it in calendar year 2024. But we'll see how quickly it can get there. But it's great. And there are two different patches that are coming that have kind of made it to that portion where we just need the FDA to help us with the factory.
Well, that's great. I mean, it's just one extra, hopefully, approach that we'll have. So you mentioned the dyskinesias you think probably are going to be reduced. Are there any other side effects that may be better by taking it subcutaneously? Some of the GI side effects, for instance, or that sort of thing?
Yeah, so GI could be a benefit. We might see some reductions over time. However, we do have to remember that anything when it hits the bloodstream, anytime dopamine hits the bloodstream, you can get upset stomach, right? You can get nausea. In fact, Ipecac, old-fashioned Ipecac, when we used to give that to people and they have overdosages, you give somebody Ipecac, they vomit because of the Ipecac. That's actually giving people dopamine. So if you get the dosages high enough, you can give people nausea. People did pretty good in the trials on it. So, I think one of the tricks of the business is just wait and see, and let's let a lot of people try it and see how they do with it. But we're pretty good at managing the nausea, so I think it's going to be fantastic. I think it's going to help a lot of people. That's my guess. That's
great. And I think that's one of the things that we really do face with dopamine replacement is that, that kind of up and down of the concentration in our systems and how our symptoms react to that. Are there other oral medications that might be coming out in the near future that address that sort of cyclic up and down that we currently have?
Yeah, so there's still been a lot of interest in folks looking at at chemicals that are going to go to the dopamine agonist receptor to straight, you can either replace dopamine, so we talked about that. You can go to dopamine agonist. There's a couple of those and everybody who's listening today that says, what's new? And I always said back in that 10 Secrets book, the last secret is always ask what's new. pressure doctors, pressure people. That should be part of every appointment that you see. And what you're seeing is a group of folks that are interested in not just the dopamine system, okay, but you're seeing folks say, okay, Parkinson isn't just a dopamine disease, and we shouldn't be so dopamine centric. And in fact, we've gotten so good at dopamine. And as we get better with continuous dopamine, let's start, Soania, to start thinking about these other systems. So certainly we can tickle with dopamine agonists. And guess what? It works. It's longer acting with dopamine agonists, but there's more side effects. And so there was sort of this rebound effect on dopamine agonists, and people have kind of pulled back and said, okay, well, if you're going to use them with monitoring. And then there are groups of folks that are trying to combine different things together. Could you combine dopamine extending medications with MAOB inhibitors? Could you combine an MAOB inhibitor with something else? And so we're beginning to see the birth, like that first book in Genesis, like where you say, like that first story. Okay, the story of Parkinson's disease has been the story of dopamine replacement. It's been the story, right, Soania, of deep brain stimulation and making lesions in the brain. But the next story is going to be one about combination therapies. We saw this in cancer, okay? We saw this in HIV. And now you're starting to see it, okay, just the beginning of it in Parkinson's disease. And the idea being, if you can get your foot down, like they say, like in athletics, you can get, if you got a cleat and it's got like a little spike on it, you can just get your foot in the ground with a therapy. What I mean by that is what if you get a bunch of therapies that are good and you can put them together? And that's kind of what's happened in cancer. That is what has happened in HIV. So we've seen this in HIV and AIDS. And now we're starting to see people try this. Now, of course, we always had Carbidopa, Levodopa, and the Carbidopa was helpful to get it across the blood-brain barrier and to block the nausea. But now I want people to start thinking, like when we're thinking about excitement, okay? And also you talked at the very beginning about the difference between a symptom, treating like something that's tangible. They have a tremor, they have stiffness. And then you talk about the idea of, could you slow the disease down? We're also going to see the combination therapies coming as we get things that slowly, begin to creep into this disease modification. And so hopefully Alzheimer's is a little bit ahead of us on disease modification. We're ahead of them on having better symptomatic therapies. But now imagine you get 2 or 3 things that act a little bit, and then you put them together and boom, you've got a combination therapy. So people are now looking beyond dopamine. They're looking beyond dopamine agonists. They're looking at the cannabinoid receptors. Okay, so cannabinoid receptors are way up there on people's lists. They're looking at a number of different receptors that are within the glutamate, the GLU, group of receptors. And in fact, we now know, the latest research tells us there's 1,000 different types of brain cells, 1,000 different types of brain cells. And so we have receptors and we have circuits all over the brain, and we're trying to understand what can we do from a drug targeting perspective to selectively push different aspects of the neural network. And so Parkinson's has multiple networks that are lit up and they're doing all sorts of interesting things. And we say to ourselves, okay, we're good at the dopamine. We're good at kind of the dopamine agonists. We have a few other things nipping around the edges. We might be starting to think about, disease slowing therapies, but what are we missing here in ways that we can drive the network and drive it together? So I think that folks that are listening today, I want them to think about and challenge that we need to be less dopamine centric. And if you go to clinicaltrials.gov, which is where everybody registers their trials, that doesn't mean they're legitimate or great trials, and sometimes there can be frauds on clinicaltrials.gov. So I just want to throw that out there. I know it's terrible, Soania. You would think nobody is trying to make money or rip you off or anything, and we live in a perfect world, but sometimes things happen that shouldn't happen. So sometimes things get up on there. But if you look on clinicaltrials.gov, you're going to, in general, see a lot of different receptors. And we're excited to see how these things are going to do. And so on the symptomatic side, we're looking along to see where things are going. And then also, we're looking at how we can take drug screens in animals, how we can begin to put them into humans and try different approaches with folks that are going to make sense and aren't going to flop. So we want to increase our success rates. And so those are some of the things that we're looking at.
I totally agree. I can echo that whole switch in mindset. When 25 years ago, I used to go to conferences, it was all about dopamine. And that was just sort of the central player. And now it's so much more diverse and so much more broad in terms of looking for targets, which is really encouraging. Does this mean, Michael, that we might be able to address some of the non-motor symptoms then of Parkinson's? Because as we know, dopamine replacement doesn't often help with those non-motor symptoms, which can be really impactful on a patient's quality of life.
Yeah, so we know, and I think we've talked about before, and it's worth just repeating at least one time every time that we talk with persons with Parkinson and their families, that the non-motor symptoms in general, study after study has shown collectively impact quality of life more than the motor symptoms. Mm-hmm. And so I think it's now brilliant that you have people like Ray Chowdhury and other people that have really championed this. Now we have outcome measures that we can look. And so we're not just doing studies that are dopamine centric, and we're not just doing studies where we're looking for an answer of, oh, how much did it move the motor symptoms? Okay. Especially if, Soania, you're not bothered by the motor, so you need something else. And so I think understanding these things is really critical and important. And so when we think about, some of the non-motor symptoms, we really need to redesign and think about, the particular symptoms that are bothering folks a lot. One of those is urinary symptoms, okay? Really, really underestimated for folks with Parkinson. We kind of know that the drugs that we use now for urinary symptoms, even if they say they're safe, they're making people confused, right? They're giving them cholinergic side effects. And so it's not the best. It hasn't been, kind of the best mix. We've been able to, show with some studies that using some behavioral approaches, actually with some rehab therapists and pelvic floor therapists, that actually can be helpful, which is great. We've seen people using botulinum toxin and Botox, but a lot of the folks in Parkinson disease have really struggled with that. Some have even had to use, catheter approaches while they wait for that Botox to wear off. And so maybe that hasn't been the big winner that folks thought. But we're now seeing translation back to the scientists saying, look, we kind of know the receptors that we need to handle, and we kind of know the ones we want to leave alone. And so let's begin to use designer, drugs and designer approaches. And so I think we're going to see more of a designer approach here over the next several years for some of those symptoms that are just completely, in my opinion, neglected. And then what we have, we actually pile on and make some of the other symptoms, worse. And so I think urinary symptoms is something we're going to begin to see, kind of a genesis of things. Sleeping symptoms. Can we help people to sleep with their Parkinson, and at the same time not worsen their overall symptoms? And can we do simple things? So a couple of simple things. One, taking sleeping medicine after dinner, helps to make sure it's worn off by the next day. Simple thing. Mm-hmm. Second, we've been recording out of brains, our group, many groups, and we know that these oscillations in the brain called beta oscillations, they tend to come back at 1 and 2 o'clock in the morning. And a lot of times just by reducing dopamine, it's like turning the light switch off. And then instead of staying up all night, like staring at the wall and you can't get back to sleep, you just reduce your regular dose of dopamine in the middle of the night once or twice when you go to the bathroom. That improves. We're learning some of the symptoms now that we thought were all urinary symptoms in the middle of the night. We're learning some of those are actually non-motor and they're actually anxiety. So then treating the anxiety has been, like really important, identification and treatment. And then we're seeing a shift now, and maybe this is through centers of excellence, but we're seeing a shift of people beginning to appreciate when you treat depression and Parkinson, if you think just because you gave an antidepressant to somebody that you're done, you're wrong. You're wrong. 100% of the time, you're wrong. You have to give the antidepressant. You have to watch the person. You have to see them back. Imagine that in the American healthcare system. You have to see them back, or in the Canadian healthcare, or if you're in Italy or you're in Asia today, you got to actually see them back within a couple of weeks and readjust. we also realize we, Sonia, have been making people worse. And so we're starting to see papers and investigators that are showing that when you give the antidepressants, if you get that dose up too high, sometimes you can make them apathetic. What's the number one, kind of mood affective, challenge that we have in Parkinson? We used to say it's depression, it's probably apathy. And part of the apathy is caused by us. And so we have to watch that dose. And then some folks have begun to say, hey, maybe we should be mixing in, a little bit of what's called a serotonin norepinephrine reuptake inhibitor. So that has serotonin and norepinephrine, some of the like generic drugs like Effexor. I don't favor any one over another. Actually, they all work about the same as long as you watch your person and you see them back. But mixing in a little bit of a norepinephrine inhibitor might, pep you up a little bit, cause less apathy. Watching that dose, not letting it sail up too high, using some other non-motor features. We're seeing actually a difference, I think, Soania, just in the past year or two, of people nuancing the approach to these non-motor symptoms: depression, anxiety, sexual dysfunction. And then on the anxiety front, we're beginning to see the papers coming out on cannabinoids. And nobody should be shocked when some of these randomized trials of cannabinoids come out as negative, or not working, You get one primary outcome variable on a cannabinoid trial, doesn't necessarily mean it doesn't work. There's so many strains of cannabinoids. There's so much that we don't know yet, but we do know that a lot of people that are taking CBD and taking cannabinoid drugs, it's helping with anxiety, it's helping with sleep, it's helping with pain. We need to understand why, where, and how we can begin to tailor and not just give up because we see a negative trial or two and we cluster a whole bunch of people together and study them. So cannabinoid receptors all over the brain, super important. It's going to be a super, I think, important area of non-motor. And I think the people that are looking for them to fail are going to say, oh, here, the first couple come out. Hey, listen, when they did cardiac, surgeries and bypass surgeries, everybody died when they first gave them. Obviously, not everybody's going to die if you give people cannabinoids, but here's an opportunity for us to continue to try to understand this and say, hey, we've met a lot of people with Parkinson who their pain and their sleep and their anxiety are better. Let's see, because you know what? We don't have that same sedation that we have when we give Xanax and benzodiazepines and clonazepam and things like that. And so we need better therapies. And so I think it's not only the development side, Soania, but it's also how we're doing it, how we're practicing medicine. And then we need to spread that word so we can get better at treating individuals.
That's a tremendous amount of really great information. It also underscores the complexity of this disease. It's not just a simple motor disorder, movement disorder. It's a whole body disease, and that approach of determining what's most impactful for the patient on their quality of life. I'm married to a urologist, so those urinary complications we've discussed before quite frequently, but I know that can be a significant issue for a lot of people in limiting their social interactions and so forth that really impact quality of life. So I'm really pleased to see and hear that more of a sort of holistic approach is being taken, which is really great. And it also makes it much more important to look after the symptoms of Parkinson's, not just look after the disease modification. I think both are necessary in order to serve the Parkinson's community. I'd like to switch gears a bit and talk about another type of symptomatic treatment, the surgical approach. So what's new in DBS? And as our listeners probably already know, much like a pacemaker in the heart, DBS, or deep brain stimulation, is a surgical treatment available to Parkinson's patients. And there continues to be advances in this area as well, such as adaptive DBS. Could you please tell us what adaptive DBS is and how it differs from the more traditional approach that we had in the past?
Sure. So this idea that you put a straw into the brain, and that straw is going to be connected to, some sort of engine, that provides electricity, and it goes to a wire. It's just like a pacemaker, as you said. And I love that terminology because the pacemaker, the wire goes to the heart, and here in DBS, there's actually been a movement at the last deep brain stimulation think tank with a lot of the experts together saying, we should probably call it a brain pacemaker because people don't understand like what it is, but that's really what it is. It's just like it. It's a battery, it's a wire that goes into a specific brain structure. And when you stimulate in that brain structure, it changes the network. So imagine there's a whole bunch of islands and some of the lights are on, some of the lights are off. And you when you get it into the right spot, you get this magnificent response where a group of structures come together and then a bunch of symptoms like dyskinesia, tremor, stiffness, slowness get better. Now, for many years in our laboratory, it's one of the things that I've been up to, in one of my night jobs, working in the laboratory here at the University of Florida for over 20 years, is actually looking at what those signals are. I got paid, I would joke, I got paid to eavesdrop on different areas of the brain, to listen to those cells. And many years ago, we couldn't actually take that into clinical practice. And then we did a lot of experiments, some of the early experiments on humans, where we're able to actually record out of people's brains in real time and then see what their symptoms are doing. So guess what, Soania, when I tell you now that, like I used to tell people all the time, when you wake up in the middle of the night and you can't get back to sleep, take your regular dose of dopamine. It's gonna suppress your beta oscillation in your brain. I know now because I recorded in the lab. I can see they have a beta oscillation when they wake up, right? But guess what? Now there are devices that are coming out where the actual output, the brain signals, just like in your heart, like an EKG, are coming out and your doctors can see them, okay? And, and when you see those things, you can then correlate the symptoms individually. So, if you're having a little dyskinesia right now, I can see that you might have a spike, at 60 hertz, at 60 times per second, 60 or 80 hertz, okay? So it's something that we know now from recording out of brains for many years. Now we've been able to put that into the hands of folks in the field. Now, what adaptive DBS is it's going to be that next step. Okay, we've done this in the laboratory before. I've researched, many people who know me know I've researched Tourette and kids with Tourette for many, many years and many, many National Institutes of Health grants. And so, trying to find the signals of why these kids tick, trying to find the signals of why people have tremors, right? Once you find those signals, then you teach the device how hit the signal, okay? And that's what adaptive DBS is. Sense the signal, okay? That, the little squiggle correlated to the symptom, how hit the symptom. And that's what adaptive DBS is. Now, just because we can do it doesn't mean everybody's going to need it, doesn't mean it's going to be useful to everyone. And in fact, the vast majority of people are still going to function just like, before. You put the lead in, it works fine. You don't need to waste your time looking at all these signals and everything. But then there's going to be nuances. Maybe you pick up a little dyskinesia here, a little dystonia there. Maybe you're having trouble sleeping. And we can use these signals and maybe even adapt to use them when we need them. And so it's another tool in the toolkit, okay? But the problem, and let's say the challenge, I hate the word problem, would say the challenge here is this toolbox, Soania, is getting so full from people like me filling it with all these different things that we can do, electronically. Doctors can't handle that. Persons with Parkinson can't handle that. Certainly families can't handle that. And so this is where AI, artificial intelligence is going to play a role to help us to kind of tell us when to use things, when not to use things, and how we can have all these things in our toolbox that are just going to become overwhelming, unscalable. We're not going to be able to get them to everything. But that's the idea. Now, if you have, one last comment is if you have a DBS device and it's working fine, just switching to an adaptive DBS isn't necessarily going to give you any advantage, okay? But there is some advantage to nipping the edges on some of the symptoms. And so you shouldn't panic that you don't have an adaptive DBS because now there is an adaptive, but there is sort of a movement, and we haven't gotten there to see how many people it will benefit. And, we really shouldn't get people too worried about that, but we should be excited about lots of new innovations that are coming that might help us and help others as we come along the road. But it's that sense the signal, how. That's what adaptive DBS is.
For those of us in our community who are maybe contemplating DBS in the near future, is this something that they should ask for Or are there just certain cases in which this should be implanted compared to the others?
It's a great question. And you talk to somebody like me that's been in it now for my third decade into the research and everything, and I can't really give you an answer. And you say, God, it's very humbling, right? That I can't answer that question. What I can tell you is this. If you're going to be successful with a deep brain stimulation operation, and you decide to go for it, the experience of your team matters. It
Mm-hmm.
matters that it still matters that you're seen by a multidisciplinary team like neuropsychologists, psychiatrists, neurosurgeons, that they give you dopamine, they see how you respond. All that still matters just as much.
Mm-hmm.
And one of the most important aspects of your outcome is where that lead is. And now that we have these leads that are directional, where we can push current to the left, to the right, to do all these things, people say, oh, well, I can slack off and not get that lead in the right spot. Wrong. Absolutely wrong, Soania. You want experience. Just because you have the technology, it's not going to save you from a suboptimally placed lead. So there are several different technologies. They do different things. They actually can be quite complicated. And it's really important your team gets it in the right spot, no matter which technology is chosen. And then they talk to you about, what do you want? Okay, what's most important to you? What are the individual symptoms? Do you need one? Do you need one on one side? Maybe you only need one. Maybe you don't need two. Some people are very asymmetric with their Parkinson, and we're putting two in and subjecting them to the risk. And so it shouldn't be fast food. There are multiple targets and there are multiple technologies. And we wrote a little piece for JAMA Neurology about this a number of years ago. And I think the lesson, of it was, in the end, people were struggling. And that's why we were asked to write the piece. Like, what do you do? Okay. One, you go to an experienced team. If they get it in the right spot, you're going to have the best outcome no matter what hardware they choose. But the last decision they should make, is after everything else has been screened and everything, is they should make a recommendation to you about what hardware they think is appropriate for you, and then do shared decision making with you, where you actually discuss it with them. And I think that's really important. Now, there might be a moment where things begin to emerge, that you would do this in this situation, you would do that in that situation. I'm telling you, I've been in this for 3 decades. It's still a matter of get it in the right place is the most important. And then also making sure that your local team can manage it and it's the right target, and all of those things are so much more important than the technology at this moment.
I mean, you're right. I think like any kind of treatment plan for anyone living with this disease, it has to be personalized, and that decision should be made with the patient or the person living with the disease. Thank you. Now let's talk about another really exciting area of research, the disease modification that we talked about briefly earlier. And that's the other broad category therapies that are in various stages of development. These therapies, if successful, would be able to halt or slow disease progression, or in the best case scenario, what I hope will perhaps even reverse the progression of this disease. That's sort of the ultimate goal. And I know there's a lot of research being done into disease modifying therapies. The one I want to start talking about is cell replacement or stem cell therapy research, which started decades ago. And they continue to advance, but have not yet shown, to my knowledge, to treat or cure Parkinson's disease. But many in our community are interested in the promise that they feel that this type of treatment may hold. And so I wanted to know where we are in the reality of stem cell research currently, and where are we in the area of this for focus? Where are we focusing?
So I think it's a great question. I think it's super exciting, there's a couple of different ways to look at this. You could say, well, you've been at it for a couple of decades and you're not successful. So, let's just throw away all of regenerative medicine, or perhaps we could look at it opposite and say there have been some successes, and some of the folks who have received either fetal or autologous stem cell transplantation, there have been some failures, there have been some people with dyskinesias. We've learned a whole bunch about regenerative medicine. And while that's been going on, DBS and medications and patches and everything are going in the background. So we should feel fortunate we have all of these, things that are happening concomitantly. I think that it's fair to say, okay, that after 20 years, that Parkinson's disease is not just dopamine, Okay. And so any approach, like even if it's a stem cell approach that goes just after dopamine, is only going to get dopamine. If you go after dopamine, you're only going to get dopamine. Okay. It kind of makes sense, right? And so we've got a lot of other things we have to pay attention to. Second, I think it's fair to say that the responses that we've seen with it haven't been as robust as what we would like to have seen, across here and reproducible. And that at the same time, lots of other symptoms and disease progression continues to happen, like even in these cases. And so I think we have to also think, maybe some of these regenerative approaches are symptomatic. And that's okay, right? So if I said to you, okay, I give you a transplant, Soania, and you're going to do good for 10 years or whatever, and it's going to give you good symptomatic relief, and there's going to be no generators or anything like that, could be fine, right? So I think maybe our expectations were too high. And there's something called the Gardner curve when there are new technologies. And at the beginning of the Gardner curve, something comes out. And the first part of that Gardner curve is called peak of inflated expectations. And I can think of no therapy, more than stem cell therapy, that the first, time somebody said stem cell therapy, those three words, it stuck. I mean, it stuck all the way back to George Bush administration, to them talking about how many stem cell lines they had, to getting taught. It has stuck. People are so hopeful, that you can regenerate, the brain. Okay. And we don't know what we don't know. And it is true that in the dish and in different animals and in different diseases, we are regenerating things. So let me not be the person to squash the dreams of people about regenerating brain cells and things like that. I do think that we need to refocus. Okay. And we need to think about, okay, where are we now? What have we learned? And what can we use these things for? And one of the things I find most exciting was there was a wonderful, wonderful editorial viewpoint by Bjorklund and by Roger Barker, two of the leaders in the field. And they were talking about another symptom. And these are top regenerative specialists. They were talking about the symptom of memory and cognition and the different nodes in the brain, okay, homotopic and ectopic, and where those nodes are. And it's not really important that you know the specifics. This appeared in a journal called Brain, very, very great journal. They had a wonderful picture in there. And the idea being that, that we may be able to use some of these techniques and all the successes and failures that we have to address another symptom, which is the memory loss. And, that we see in Parkinson, and then the percentage of people, a third or more, that might get, serious cognitive issues or hallucinations and things like that. I think that's like super exciting. And so they're looking, Soania, at it. And when you read through and you see these leading, regeneration, specialists, sort of pause, take a breath after 20 years and come up with a new approach based on things that they've learned, before. I think it's really cool. So basal forebrain is the area that they're looking at. So I think that is super exciting. I think the other area to look at is a lot of people in regenerative medicine, are that was kind of the early days, was cell replacement. Okay, replace the cells. And now we know there are multiple circuits in the brain that are affected in Parkinson's disease. And a lot of the younger people, okay, and remember, it's going to take a team. No one person is going to cure or come up with a big therapy for Parkinson. And Parkinson isn't one disease, it's Parkinson's diseases. But a lot of the people in the regeneration medicine field, like Claire McClellan, for example, at University of California, San Francisco, wrote a beautiful paper for us in JAMA Neurology about the use of CRISPR, technologies and so, a lot of the people that grew up in regenerative medicine and in the Bay Area and in Oxford with Roger Barker are now thinking about this. And CRISPR, it's an acronym. It stands for Clustered Regularly Interspaced Short Palindromic Repeats. And if anybody who's listening here, can say that 100 times off the top of your list, you should definitely get a bonus reward. But the idea is it's simply gene editing. And think about it this way. We are all kind of, saying, what is Parkinson, right? And we still don't know exactly what Parkinson is. We still don't know with this alpha-synuclein that makes Lewy bodies. We still don't know the why. We don't know the pathogenesis. We don't know the pathway. And a lot of people who have been at these clinical trials, and we're on here today talking about all the new cool things that are coming, are saying we need more basic research to understand What does this look like? How does it fold? How does it change? What is it in the normal state versus the abnormal state? And then you have these young people coming out of the regenerative medicine movement saying, wait a minute, we can do CRISPR, and we can do gene editing. So they bring us this potential now, that maybe we can begin to study synuclein and see what it actually does. Mark it, edit it, see what it actually does. Do small experiments. Maybe you don't need to experiment on, hundreds of people. Maybe you do a few people at a time, and then as you learn, you iterate. Okay. And so many people here on this broadcast are so tired of hearing about, oh, they just did a gigantic study and it's negative, right? And all these people were enrolled. But some of these therapies, in regenerative medicine, instead of going for gigantic therapies and in CRISPR and in nanoparticles, we can inject these tiny little particles called nanoparticles in, and they can have magnetic, properties. They can have all sorts of different properties that they change by temperature. Okay, if we do that in small numbers of people, it's actually fairly exciting. And instead of, setting the expectations on that Gardner curve, like, hey, we're going to cure this with stem cells, how about we set the expectations of we start to answer those questions that we need for people who are suffering with neurodegenerative diseases and go up the ladder, a few patients at a time, learn, apply. And so many people in the field with Parkinson are willing to volunteer and be part of this. I mean, they're the best. I mean, they're the best, folks I've worked with in my whole career. And so, thinking about these technologies, up conversion of nanoparticles, magnetothermal nanoparticles, ultrasound responsive small particles, could we do regeneration in between two circuits or whatever? So I think that this idea of maybe the post-stem cell depression era, I would kind of encourage people to say, look, don't be depressed, okay? But don't think of it like we thought of it 20 years ago. Don't think you're just going to stick the cell in and it's going to reconstitute multiple very complicated circuits. Not even, the best stem cell biologists who are in Parkinson think that. But if we can understand how it works, we can understand, what it does. We can use these technologies like gene editing and CRISPR. We can begin to walk up by asking questions that make sense. We're going to get to more therapies and we're going to get to more combination therapies.
Well, that's great. I think you can't cure what you don't know. So it's exciting to hear that the technology is now allowing us to gain a greater understanding of the disease. Because as you said, if you put dopamine cells in, replace dopamine cells, you still haven't fixed the underlying pathology that caused the Parkinson's cell or the dopaminergic cells to degenerate in the first place. So I think that's really exciting. The other one that I wanted to ask you about when we're talking about disease modification is the exenatide phase 3 results. And our listeners may have heard of one of it belongs to a broad group called the GLP-1 glucagon-like peptide receptor antagonists. And they've actually been making headlines since last year. The advent and use of the drug Ozempic, which was initially designed for type 2 diabetes, but it's used in droves of people to lose weight and touted in the media pretty much as a cure-all for many illnesses, is an example. And another similar drug, exenatide, has been studied in the treatment of Parkinson's disease, and results of a phase 3 trial for this are due out this year. What is the expectation of this trial?
So there's this sense, over time, a growing sense that people with diabetes were getting more Parkinson. Okay. Mm-hmm. And then they started to study it and they said, wow, type 1, type 2, we're starting to see it. Yeah, maybe it's true. Then they do a few more studies from a few more countries. There's a lot of countries around the world that start to say, there's something here, right? So then researchers started to look and they said, okay, what happens when you're on certain diabetes drugs? Okay. And so one of those drugs is these GLP-1 agonists. Okay. These are those drugs that go to a receptor, okay, and they are brain-derived receptors, okay, and they help the diabetes, okay, and a lot of people are using these to lose weight, okay, as well. But they looked, okay, so let's hold the weight loss timeout. I know everybody's excited about that, but timeout on weight loss, okay. They looked and they said, okay, so if you're on these drugs, okay, did you get less Parkinson? Answer, yes. Okay, pretty interesting. And in fact, Soania knows because she and I have spoken before, and we talk about all the new things that are coming out in Parkinson. For many years, different diabetes drugs have been on that list, that hit list. When we do drug screens and everything, it's a hit list. And diabetes, malaria drugs, lithium, these things tend to hit that list, for whatever reason. There's some properties of these drugs that are really interesting. Okay. So then folks said, okay, well, we've got, we don't have a smoking gun. Okay. But we've got this evidence that about diabetes and Parkinson relationship. We've got this evidence of folks with less. Then let's look in the laboratory. So then people started to look in the laboratory and do experiments with synuclein. Now it's hard to judge because, of course, we're talking about animal models and animals and humans and everything. But then they started to look and say, there might actually be some pathophysiological differences that happen when you use a GLP-1 agonist in animals on synuclein and on Parkinson models, and they start to say, this is getting very interesting, okay? So then Tom Foltini and his colleagues in Oxford, and actually there's been 3 or 4 different groups that have studied different GLP-1 agonists, began to look at this. The one that caught the most fire was exenatide, okay? Exenatide is one of these drugs that's given, okay, for diabetes. And the idea was in the early studies with Foltini and colleagues, they were looking to see whether or not, okay, and you have to look at off medicine, on medicine, and they looked in the off medication, off dopaminergic condition. Remember, studying Parkinson is so complicated, Soania, because you have to know, are this person on med? Are they off med? Are they early Parkinson? Are they later Parkinson? Which form of Parkinson do they have? So we could be failing, we could be succeeding and failing at the same time because there's so much chaos, like in how we design the studies. And so in that exenatide study, the early studies, the imaging studies and things looked pretty good. The later studies, looked like, not, quite as convincing, okay, with it, but still alive. A couple of other groups, kind of some borderline stuff, but didn't really get over that threshold, okay? This week, okay, we're going to see a different one, okay, that we haven't talked about. You're going to see the results of that coming out this week. It's embargoed, so I can't tell you what the results are going to be, but you should watch, okay? And you should watch. And because you all are the most educated, of Parkinson folks around the world, watch. Look at, what kind of people were enrolled, what, when were they on their medications, or not? What was the effect, okay? Was it a symptomatic effect? Did they get better? Or did they get worse? Was the improvement in motor symptoms? And some of these GLP-1s, they say the improvement is in motor symptoms. Some of them, they say it's in non-motor symptoms. Why is that so? So we need to understand. So there's some signal that we're picking up. And I think this week we're going to have more discussion on this, but that's why it is of interest. Now, couple of points for folks here. Don't run out, like we talked about, you and I had talked about, don't run out and get the cough syrup, okay, and make yourself, like woozy on cough syrup. Like last year, we talked about G-case and the Ambroxol story. Not ready for everybody to run out. You can get side effects and things, and there's reasons not to do that. This year, don't be running out all the time and thinking diabetes, and people have already been doing that. And remember, we had that with cancer drugs, with several of the cancer drugs that look like the leukemia drugs might have a Parkinson effect. People ran out, took a bunch of these cancer drugs, and then it ended up, kind of not being the story that we thought it was going to be. So pause, time out a little bit, pause. These drugs do cause nausea, okay? And they do cause weight loss. And weight loss is something that you don't want in Parkinson. I know we all kind of want weight loss, but in Parkinson, you want to be a little heavier rather than a little lighter because you continue to lose weight. So nausea, vomiting, weight loss are things that we watch out for. And so no matter what, happens, as more of these studies are going to come out and you're going to see a whole bunch of GLP-1 stuff coming out, and but just don't run out yet to the store, just like with the cough syrup on it. It is very exciting. And more than anything, Soania, it should lead us to more questions of why. Like, why is this? Why are we seeing the effect? Can we hone in on that and really, lean in on our failures and our successes and try to, make something out of the diabetes story?
Just in the last couple of minutes, there was a couple of other developments I was hoping to ask you, but it heralds back to what we discussed at our discussion last year when we spoke about the alpha-synuclein seeding amplification assay. So where do we stand with biological definition, staging, and classifications for Parkinson's? And that might be a little too much to answer in a couple minutes, but I was particularly interested because that sample was taken from spinal fluid in developing that seeding assay. Now we hear of blood tests that may be able to be performed that may also reflect what's going on in the brain, and skin biopsies as well. So
Yeah.
could you talk a little bit about that?
Yeah, I'll give you my summary version of things. Okay. So if you are, first of all, if you have Parkinson or you're being, already been diagnosed, already responding to dopamine and everything, okay, the only thing that these types of assays are going to help with is for clinical trials, okay, and classifying you and things like that. You don't need to get another diagnostic test. There's also, okay, an increase in things coming out. And so I see, lots of comments coming earlier about the skin test. Skin test looks really good. Okay. There's a blood test from the Japanese group, okay, that does the same thing with synuclein, but it also tells the difference between multiple system atrophy and Parkinson. Now you're like even adding more because we really need to do that. We need to sort this out, what the different diseases are. And so when you can cluster together things, you want something that's going to be available, it's going to be economical for people, it's going to be affordable, it's not going to take certain countries and certain people and certain groups out of participating in research. Preferably not a spinal tap if you could get it. I mean, if you end up with it, you end up with it, but it doesn't look like we're headed in that direction. And then you want to smash it together, validate it, and ask yourself, what am I doing this for? I know that sounds dumb, but let me just say, what am I doing? Am I making a scale to test something in a clinical trial? Am I making a scale to classify somebody? Am I making a scale to tell somebody where they are with their Parkinson? Or am I just making a scale so I know how to communicate with other doctors? You have to ask yourself what you're doing. And so what we're going to see now, Soania, is you're going to see people moving toward blood, moving towards specifics of can we tell the difference between Parkinson, smashing techniques together. Okay, so we're going to have blood, we have CSF now, we have DAT scans. Well, we need DAT scans, we have skin biopsies. Maybe that will be better than the DAT scan. And then MRI is going to make a comeback here. And everybody gets an MRI for their workups when they get degenerative diseases. So I predict MRI is also going to make a comeback. And then we're going to put it together, just like cancer did, just like Alzheimer's did. We're going to come up with a classification. It's going to help us to do clinical trials. It's not going to exclude everybody as long as we don't go too fast and we're not trying to satisfy one or another person's agenda, and all the stakeholders are together and we decide together what we mean by this. And it's not just telling whether you have some form of Parkinson's. If we can get closer to like what you have, what form of Parkinson, that's going to be important. So I think that's where we're at. I'm excited. I'm just trying to you pull on people's coattails, slow people down a little bit. It's the data is going to get us there, and everybody's so excited to get there. If we just slow down a few years, we're going to get it right. It's more important we get this right on classification and diagnosis than it is for us to get there quickly.
Wow. I can't believe our hour is pretty much done. But as we come to the end of our time together, we've obviously covered a lot of exciting information. But if you had to pick one emerging therapy that is most exciting to you, one that may be coming out to our community sooner rather than later, what would that be?
Yeah, so I lost you there for a second, but you're talking about one therapy, like choose one thing, for the community.
That would be coming out sooner to patients rather than in the distant future.
Yeah, I mean, I think that going all the way back to our first question here today, and it's always so much fun to do. That's why I always say I have to do this with Soania because we always have so much fun together. If we go back to that very first question, I think the thing for folks to be hopeful about here is the new dopamine patches coming. And, and will it play a role, for you, and will it be useful? That's like right here. Okay. And I always want to stress to people, like there is tomorrow and there is today. And there are so many people today that have Parkinson, and we need to do something for you today. Okay. So I think that's the thing that looks most tangible, has great data, has been validated and is going to make a difference today. So that would be where I would hang my hat on today. Okay. Tomorrow, where I hang my hat is, guess what? Our basic scientists are actually starting to talk to our clinicians a lot more, understanding that disease more. I think we're going to see some real, advances that are going to help us to understand what synuclein really does, what it really looks like, and then how we can package together combinations of therapies to help people and separate both, symptomatic versus protective. And could we begin to have a new generation of regenerative medicine with memory? That'd be really cool. Can we pay attention to apathy? Could we pay attention to some of these other non-motor symptoms? I think it could be really cool. So those would be the things I would look at. But right away, I'm excited for people to see those opportunities open up.
Thank you so kindly, Dr. Okun, for your time and expertise. And thank you all for joining us today. And I hope you found the discussion just as helpful and educational as I did. And so remember, everyone, we may not have a choice in our diagnosis, but how we face the life challenges that this disease brings is really ours to define. So choose to optimize your quality of life, choose to educate yourself, empower yourself, and celebrate your daily victories. Until next time, be well and stay safe. Thank you.